All right, moving now into our section on respiratory and iatrogenic disorders. We're talking about disorders of respiration because there is a reciprocal relationship between respiration and swallowing disorders. Once the respiratory system gets to a certain level of weakness or incapacitation, dysphagia is going to be the result. And once dysphagia gets to a certain level of severity, then respiratory function, respiration is going to be compromised. So we already mentioned this when we talked about the relationship between pneumonia and dysphagia and how one can cause the other. Dysphagia can create pneumonia, but also how pneumonia can create dysphagia. We use the term iatrogenic disorder to refer to problems that arise from treatment for something else. So when we talked about the fibrosis of the musculature of the head and neck that creates dysphagia or creates mastication problems, that would be caused by the radiation that is the treatment for the cancer. So in that way, all those problems resulting from the radiation that we discussed are iatrogenic. Other examples can be the negative impacts on swallowing that are the result of a patient being too reliant on their ventilator, which essentially means their body becoming too weak, or problems that are a result of having a tracheostomy or certain medications in place, or being intubated for surgery, which can cause problems.
You may receive endotracheal intubation and mechanical ventilation if you are in an emergency situation involving severe respiratory problems, or if you are having general anesthesia during a surgical procedure. When you breathe, air moves into your lungs when a muscle called the diaphragm, along with other muscles nearby, contracts and causes the chest cavity to expand. Air is exhaled when these muscles relax, and the lung tissue passively returns to its original size. This is called respiration. During respiration, oxygen in the air passes through your nose or mouth and into your pharynx or throat. It then goes into your trachea or windpipe. Your trachea divides to become the left and right main bronchi, which enter your lungs. Inside your lungs, the main bronchi divide repeatedly and eventually become small tubes called bronchioles. At the end of the bronchioles are tiny air sacs called alveoli. Oxygen in your alveoli is absorbed into nearby blood vessels called capillaries. At the same time, carbon dioxide, a gas in your blood that must be removed, passes into the alveoli and back out through the airways. This process is called gas exchange. If you have severe respiratory problems, the oxygen levels in your blood may drop too low, or the carbon dioxide levels may rise too high. Either of these conditions can result in damage to your vital organs, including your heart and brain. Some conditions that may lead to severe respiratory problems include drowning, an obstruction in the trachea, such as a foreign object or tumor, obstructive pulmonary diseases such as asthma, chronic bronchitis, and emphysema, diseases such as pneumonia and acute respiratory distress syndrome, or ARDS, severe weakness of the muscles that control breathing, and damage to the bones and tissues of the chest. Under these circumstances, you may need additional oxygen or breathing support through mechanical ventilation. Mechanical ventilation is also used during surgical procedures, for delivering anesthetic drugs, preventing the aspiration of stomach contents into the lungs, and closely controlling the levels of oxygen and carbon dioxide in the blood during surgery. Before you are intubated and ventilated for a surgical procedure, an intravenous line or IV will be started, and your doctor will give you medication through your IV to put you to sleep. As the medication takes effect, he or she will place an oxygen mask over your nose and mouth and ask you to breathe deeply, ensuring that you will have a reserve of oxygen in your system prior to the procedure. The first step in mechanical ventilation is called endotracheal intubation. Once you are asleep, your doctor will use an instrument called a laryngoscope to perform the intubation.
And it's not uncommon for the patient to suffer trauma from being intubated. So trauma to the vocal folds of the larynx that then creates swelling, that creates problems. Or I used to work with a nurse that swore that she would only be intubated by someone she knew, because she was afraid she'd send too many people. Doctors knock out the teeth of the people that they were intubating with the laryngoscope.
A laryngoscope, which consists of a handle, light, and dull blade, helps guide the endotracheal tube to its proper position. Your doctor will tilt your head back slightly and insert the laryngoscope through your mouth and down into your throat, taking special care to avoid contact with your teeth. Using the blade, your doctor will gently raise the epiglottis, which is a flap of tissue protecting your larynx. He or she will then advance the tip of the endotracheal tube into the trachea. Once the endotracheal tube is in the trachea, your doctor will inflate a small balloon surrounding the tube to make sure it remains snugly in place. Your doctor will remove the laryngoscope and tape the tube to the corner of your mouth to prevent it from being jostled out of position. Your doctor will check to see that the tube is properly positioned in the lower part of the trachea by inflating your lungs with a special bag and listening for breath sounds on both sides of your chest. If the end of the tube is too low, both lungs will not receive the same amount of air. In some cases, an X-ray is taken immediately after intubation to confirm the tube's placement. Once the endotracheal tube is in the proper position, your doctor will attach it to the mechanical ventilator, a specially designed pump that aids respiration by delivering well-oxygenated air into the lungs and permitting carbon dioxide to escape from the lungs. Levels of oxygen and carbon dioxide will be closely monitored to confirm that the ventilator is working. Once your surgical procedure is complete, your doctor will not remove the endotracheal tube until you are able to safely breathe on your own. He or she will make this determination by measuring how often you take a breath.
So you can see when this balloon or cuff is inflated that you are not able to breathe past it, right? So any air coming in or out of your system is going to go through that ventilator. So the ventilator tube that you saw in that video is referred to as an endotracheal tube or an endotrach. It is designed so that you can put that person's body on ventilator support. These are usually put in place for a limited amount of time. This is a short-term solution to respiration, and it's usually done through the course of a surgery, as you saw in that video. The longer the endotracheal tube is placed, the more problems it's likely to cause. So you can imagine if you have that tube going down in your airway, and then you have that cuff inflated in against the sides of your airway, then there's possibly lesions that's happening to the trachea, to the vocal folds where they're like closing on that tube, or at the epiglottis where that tube is passing around. So it's not uncommon for people to have problems with their voice, with their swallowing after intubation, so after being extubated. So patients that are on a ventilator are having their tidal volume controlled by the ventilator. They're having their rate of respiration, the respiratory cycle, the speed of the respiratory cycle controlled by the ventilator. And they're also having the percent of oxygen in the air that they're breathing controlled. And generally speaking, the doctors want the patients to be as least dependent on the ventilator for respiration as is possible. So as soon as that patient start to showing signs of strength, the doctors will start turning down the strength of the ventilator, prompting the patient's body to start taking on some of the responsibility for breathing. And you're talking about increased muscular action, increased muscular strength to complete that respiration. So that's the difference between a patient being completely dependent on the ventilator, where they are incapable of respiration without that machine that is pushing air into them, versus a ventilator assisted patient that has some respiratory capability still themselves, but they're not completely independent of the ventilator, and they still need the ventilator to complete respiration, and maybe only for certain times of the day when they become more fatigued. So patients can be connected to a ventilator through the endotracheal tube, as we've just covered. Here's an image of that here. They could be connected to the ventilator through a mask, as you see here, or they could be connected to the ventilator through a tracheostomy, like this guy. So how ventilators work is normally they are only delivering inspiration. So they're pushing oxygenated air into the body. And then that pressure, that positive pressure that's pushing air into the body, turns off, and the body is in an expanded state, having just inspired. And from here, the body, the tissues of the body, the diaphragm retracts upwards. The tissues and muscles of the thorax retract inward, passively pushing air, passively squeezing the lungs to create that positive pressure, positive alveolar pressure that is going to push air out of the body. So expiration is normally a passive process when a person is on a ventilator. So there's something called PEEP, or positive end expiratory pressure. And what PEEP is during a passive expiration. So the patient is on a ventilator and their body is squeezing air out of their body. Even during an expiration, the ventilator is still applying a little bit of positive pressure to the lungs, so that when the patient gets at the end of that expiration, there's still positive pressure, a little bit of positive pressure being pushed in their body, keeping the alveoli slightly inflated. And this is important because it keeps parts of the lungs from collapsing and becoming a problem for respiration.
Demonstrate PEEP without having access to a cadaver. If you haven't seen it, go to aimairway.ca, look at our videos, or go on a YouTube channel, and you'll be able to see the effective PEEP with a lung window cut in a cadaver. And it's pretty dramatic, and to illustrate the effectiveness of PEEP. But if you don't have access to these, here's a simple jury rig demonstration. I've got two gloves taped on BVM. This one has no PEEP valve. This one does have a PEEP valve, and it's dialed up somewhere between 10 and 15. So let's look at bagging a patient without PEEP. And what you're going to see with this is you're going to see the alveoli inflate and give you the finger, and then they're going to collapse. Okay, so that's with no PEEP and fairly aggressive bagging. Now, when I take the same glove, and I've modified the glove slightly to make it more dramatic, and here I've dialed this up to somewhere between 10 and 15, and we're going to see the effect of PEEP in this scenario. So again, you don't see any collapse of the alveoli. They stay open progressively. And even after I stop bagging the patient, no fingers, just giving you a high five. PEEP's the way to go. Use it.
The force with which the ventilator pushes air into the lungs is going to vary depending on the needs of the patient. The rate of the respiration that the ventilator delivers unto the patient is going to change based on the needs of the patient, as will the level of oxygen in the air that's being delivered. All right, so let's acknowledge that if you're on a ventilator, your inspiratory and your expiratory cycle are going to be pretty rigidly timed by the machine. So if you are able to take food by mouth in that situation, it may be difficult because you have to time your swallow in the inspiratory-expiratory cycle appropriately. And this can be a problem if you have a delayed swallow. It can be a problem if you have cognitive deficits. And obviously, swallowing itself might be difficult or a chore with the endotracheal tube in place, because that tube is going to be passing from your pharynx down into your airway. And this is why most people that have an endotracheal tube are probably also going to have a nasogastric tube, so going through their nose down into their esophagus, that is going to be delivering food to their stomach. But once again, like the endotracheal tube, the nasogastric tube is only a short-term fix. You don't want that to stay in place for very long either, or it's going to be irritating structures and creating problems. So patients can be intubated for different reasons. Surgery is probably one of the more common ones, as is a patient with arousal deficit as a result of traumatic brain injury. Your traumatic brain injury patients often are intubated, are hooked up to a ventilator, and have an NG tube. After patients are extubated, as we've already mentioned, they're likely to have some problems with speaking and swallowing due to negative changes at the level of the vocal folds. This could be swelling of the vocal folds or the potential lesions on the vocal folds that are keeping them from adducting medially appropriately. Parikh et al. In 2000 found that 86%, so most of their 21 patients that they looked at, showed signs of aspiration after being intubated. And those patients were intubated for an average of 24 or 25 days. And the problems that they were primarily showing was in the realm of oral stage weakness and problems in laryngeal elevation. So this could be attributed just to general atrophy of the musculature that is usually involved in mastication and deglutition. We have a 1995 study that tells us that most of the people they looked at recovered their normal swallowing abilities within 7 days of being extubated. So suffice to say, there's a wide variety of problems with mastication and deglutition that is the result of having an endotracheal tube.